Welcome to the deep dive. Today we're digging into hypokalemia.
Low potassium, yeah.
It sounds maybe a bit niche, but really touches on, the fundamental balance of things in your body.
Exactly. We're looking at what it is, why it matters, based on some pretty detailed medical info.
So the goal is to kind of pull out the key things you need to understand about it.
That's the plan. Make it clear.
Okay, so normal potassium in your blood serum. That's usually between 3.5 and 5.5 milliQL, right?
Correct. And hypokalemia is when it dips below that 3.5 mark.
Got it. But here's something really crucial right off the bat. We measure it in the blood, but almost all of it, like 98%, is actually inside our cells.
That's such a key point. The blood level is just, well, a snapshot. It doesn't show the whole picture of the body's potassium.
So the serum level is important, but it's just the tip of the iceberg.
Precisely. So, yeah, our mission here is to explore what causes this imbalance, what the effects are, and, potential complications.
Okay, let's start with the basics then. Why is potassium so important in the first place?
It has several really vital jobs. Number one is maintaining the right fluid volume inside cells. Cellular hydration, basically.
Okay. Keeps the cells plump, so to speak.
In a way, yeah. And it's also essential for loads of enzymes to work properly. It acts as a cofactor.
A helper molecule.
Exactly. Helps those biological catalysts do their job.
And then there's the electrical side of things, right? Especially for tissues like the heart, nerves, muscles.
Absolutely fundamental there. Potassium plays a huge role in what's called the resting membrane potential. That's the electrical charge across a cell membrane when it's just resting.
And how is that maintained?
By a tiny, super important pump called the sodium-potassium pump, or Na plus AT, K plus ATPase if you want the technical term.
Right.
It's constantly working, pushing sodium out of the cell and pulling potassium in.
Like a little gatekeeper.
Yeah, ensuring the ion balance is just right.
So if that balance gets messed up, especially if potassium levels outside the cell change quickly, that causes problems.
Big problems, especially for those electrically active tissues we mentioned. If the potassium outside the cell drops fast, the cell membrane becomes hyperpolarized.
Hyperpolarized, meaning?
It makes it harder for the cell to fire off an electrical signal. Think of it like turning down the sensitivity.
Ah, okay. And that leads to?
Induction disturbances, issues with how signals travel. That's why you see effects on heart rhythm, nerve function, and muscle contraction.
Makes sense. So how does someone actually get hypokalemic? The sources mention three main ways this can happen.
Yeah, three main pathways. The first one is pretty straightforward, just not taking enough potassium in. Decreased intake.
Okay. Like not eating enough potassium-rich foods.
That's part of it. Conditions like anorexia or starvation obviously limit intake.
Right.
Also, getting IV fluids for a long time that don't have enough potassium added, that can deplete you.
Okay. And there was a weird one mentioned. Bentonite clay, like in cat litter.
Yeah, that was surprising. Apparently, ingesting bentonite clay, and yes, it's found in some clumping cat litters, can actually bind potassium in your gut.
So you don't absorb it.
Exactly. It reduces absorption. Shows how unexpected things can affect electrolytes.
Wow. Okay, so that's decreased intake. What's the second pathway?
Actual loss of potassium from the body. Losing too much.
And how does that happen? Gut issues.
Definitely. Gastrointestinal loss is a big one. Think persistent vomiting or diarrhea. You lose a lot of electrolytes that way.
Makes sense.
And interestingly, obstructions in the gut can also cause it, like a blockage in the stomach outlet, the pylorus, or even lower down.
How does an obstruction cause potassium loss?
Well, it often leads to vomiting, or it messes with how fluids and electrolytes are absorbed or secreted in the intestines.
Got it. So GI losses. What else?
The other major route is through the kidney's urinary loss. The kidneys are central players in potassium balance.
So if the kidneys aren't working right.
Big risk for hypokalemia. Chronic kidney disease is a major factor. Also, a condition called renal tubular acidosis, where the kidneys can't conserve potassium properly. And even hypokalemic nephropathy, that's kidney damage caused by low potassium itself.
A vicious cycle, potentially.
It can be. And anything that causes excessive urination diuresis can flush out potassium.
Like after a urinary blockage is cleared. Post-obstructive diuresis.
Exactly. Or even just getting lots of IV fluids without enough potassium replacement. Dialysis, too, both hemo and peritoneal, can sometimes lead to losses.
Are there hormonal causes?
Yes, hyperaldosteronism. Too much aldosterone tells the kidneys to dump potassium.
Okay.
Even low chloride levels, hypochloremia, can indirectly mess with how the kidneys handle potassium.
And medications. I know some diuretics are famous for this.
Absolutely. Loop diuretics are a common culprit.
Mhm.
Also, the antifungal amphotericin B and certain types of penicillins.
And rattlesnake bites, that came up again?
Yeah, rattlesnake envenomation can cause urinary potassium loss, probably through kidney damage from the venom.
Wild. Okay, so decreased intake, increased loss. What's the third pathway?
Translocation. This is where potassium shifts out of the blood and into the cells. So the total body potassium might be normal, but the blood level drops.
Huh. How does that happen?
Several triggers. Giving glucose, especially with insulin, drives potassium into cells along with the sugar.
So treating high blood sugar can temporarily lower potassium.
It can, yes. Insulin itself does this too. Sodium bicarbonate administration can also cause this shift.
What about stress hormones?
Catecholamines, like adrenaline, yep, they can push potassium into cells. And the body's acid-base balance matters too.
How so?
When the blood is too alkaline alkalemia, potassium tends to move into cells.
Okay. And certain drugs.
Overdosing on beta-2 agonists, like albuterol inhalers for asthma, can drive potassium into cells.
And there's that specific cat thing, Burmese cats.
Right. Hypokalemic periodic paralysis in Burmese cats, it's genetic. They have episodes where potassium suddenly shifts into muscle cells, causing weakness.
Fascinating. And the rattlesnake again?
Yes, envenomation is also listed under translocation, though the mechanism there is less clear. It really shows how one thing can hit electrolyte balance from multiple angles.
Definitely highlights the complexity. So, okay, hypokalemia develops in these ways. What does it actually look like? What are the signs?
The neuromuscular system often takes a hit. Generalized muscle weakness is common.
How severe can that get?
It can range from mild weakness to affecting the breathing muscles, which is obviously very serious. Muscle cramps are also pretty typical.
Any general symptoms?
Yeah, just feeling lethargic, maybe confused. The GI system can react too.
Like nausea.
Vomiting, loss in appetite, anorexia, and things can slow down in the gut. Decreased bowel motility. That's well known in humans, probably happens in animals too.
Okay. What about metabolically?
It can mess with how the body handles sugar, causing carbohydrate intolerance, weight loss can happen.
Yeah.
And it often throws off the acid-base balance, usually leading to metabolic alkalosis.
And the kidneys. Can it affect them directly?
Oh, yes. You might see increased urination and thirst PUPD. The kidneys might lose their ability to concentrate urine, that's hyposthenuria. And long-term, it can cause kidney damage, nephropathy, even kidney failure.
Are there any really specific telltale signs to look for?
One classic sign, especially in cats but also seen in dogs, is ventroflexion of the neck.
Meaning their head droops down.
Exactly. They can't hold their head up properly due to neck muscle weakness. And as we mentioned, that severe respiratory muscle weakness leading to failure is a critical sign.
Okay. So, given all that, who's particularly at risk?
Well, generally, anyone with conditions that cause those pathways we discussed, increased loss, translocation, or poor intake.
Right.
But more specifically, those young Burmese cats with the genetic condition are a definite risk group.
Okay.
Also, animals on diets that are very acidifying and really low in potassium.
Makes sense.
And patients undergoing diuresis or on dialysis, especially if the fluids aren't right.
And maybe just generally unwell animals.
Yeah, chronically ill animals, especially those not eating well and losing muscle mass, they're definitely more susceptible.
So if you see signs that could be hypokalemia, what else might be going on? What's the differential diagnosis?
Good question. You have to rule out other things. If you see that increased urination and thirst, plus high blood sugar and sugar in the urine.
Diabetes mellitus.
Yeah, check for that first. If it's PUPD but with signs of kidney failure, like high BUN creatinine and dilute urine.
Then chronic renal failure or another kidney disease is high on the list.
Right. If the main signs are vomiting, metabolic alkalosis on blood gas, and low chloride.
Think upper GI obstruction.
Exactly. If there's metabolic acidosis, but the urine pH is surprisingly high, like over 6.5.
That could be renal tubular acidosis.
Could be, yeah. Kidneys aren't acidifying the urine like they should.
And if you know there was a urinary blockage that just got resolved.
Then post-obstructive diuresis is a likely cause of any subsequent electrolyte shifts.
And of course, the young Burmese cat with weak spells.
You'd strongly suspect that hypokalemic periodic paralysis.
Okay, so how do we confirm it's hypokalemia with lab tests?
Well, the direct measurement is serum potassium, but there's a crucial note about how you collect the blood.
Oh.
Using the wrong tube, Specifically, a purple top tube with EDTA anticoagulant can sometimes give a falsely high potassium reading if the tube isn't filled
Why
properly.
is that?
EDTA itself contains potassium salts, so a red top tube, which lets the blood clot so you test the serum, is preferred for accuracy.
Good tip. Assuming the sample's good, what else might the lab show?
Well, other tests help pinpoint the cause. Like with diabetes, you'll see the high glucose, maybe ketones.
Right.
With kidney failure, you might see anemia, high BUN, and creatinine, the dilute urine we mentioned.
What about acid-based stuff?
Low bicarbonate or CO2 could point to a renal tubular acidosis or severe kidney failure. High bicarbonate or CO2 suggests metabolic alkalosis, which can cause a result from low potassium.
Okay. Any more specialized tests?
You could measure aldosterone and renin levels if you suspect hyperaldosteronism. High aldosterone with low renin points that way.
Uh-huh.
Measuring how much potassium the kidneys are excreting in the urine, the fractional excretion, can help determine if the kidneys are the source of the loss.
Okay.
And ACTH stimulation tests can check adrenal function overall.
What about looking inside? Does imaging help?
Definitely. X-rays and ultrasound are really useful. You can look for GI obstructions, check out the kidneys for signs of chronic disease, or look at the adrenal glands.
For tumors or enlargement?
Exactly, things that might cause hyperaldosteronism.
Is more advanced imaging ever needed?
Sometimes. An upper GI barium study can give a better look at the digestive tract if you suspect an obstruction.
Okay.
And CT or MRI scans give really detailed views of the adrenal glands if needed. For gut issues, sometimes an endoscopy is done to look directly inside.
All right. So we've diagnosed it, maybe found the cause. How do we treat hypokalemia? Seems like the severity matters a lot.
Absolutely critical. The approach really depends on how low the potassium level is.
So for mild cases, say 3.0 to 3.5 millieql.
Usually, just oral potassium supplementation is enough, giving it by mouth.
Okay. What about moderate, like 2.5 to 3.0?
That usually warrants inpatient care, so admission to the hospital might need oral plus maybe some IV supplementation and definitely close monitoring.
And severe cases?
Yeah.
Below 2.5.
That's serious. Definitely needs hospitalization for intensive IV potassium fluids. Monitoring has to be super close, especially in cats.
Why cats specifically?
They seem particularly sensitive to cardiac arrhythmias and breathing problems when potassium gets critically low, so vigilant ECG and respiratory monitoring is key.
Gotcha. And there are guidelines for how much potassium to add to IV fluids.
Yes, the source mentions specific tables based on the current potassium level, and crucially, there are maximum infusion rates you shouldn't exceed.
To avoid giving too much too fast.
Exactly. Unless it's a truly life-threatening situation, like potassium below 2.0, and you have continuous ECG monitoring, then a slightly faster rate might be cautiously considered.
What's the actual medication usually used?
For oral use in milder cases, potassium gluconate is common, things like Tumol K. The source gives a starting dose.
Okay.
About a quarter teaspoon per 4.5 kilos body weight, twice a day with food. That's roughly 2 milliequivalents.
And for a bye.
That's usually potassium chloride added carefully to the IV fluids according to those guidelines. Using an infusion pump is really important for accuracy.
To control the rate precisely.
Yes, and as the patient improves, you monitor the levels and gradually taper the supplementation down.
Are there times when you absolutely should not give potassium? Contraindications?
Yes, definitely. You wouldn't give it if the patient already has high potassium hyperkalemia, obvious one.
Right.
Also, in untreated Addison's disease, hypoadrenocorticism, or if you're giving glucose or insulin without addressing the potassium first, or using sodium bicarbonate inappropriately.
What about kidney issues?
Significant kidney failure or severe impairment is a major caution or contraindication. Also, acute dehydration, severe red blood cell breakdown, or if the gut isn't moving properly, need to be very careful.
So even when it is needed, proceed with caution.
Always. Avoid giving too much, monitor frequently. Overshooting is dangerous too.
Does potassium interact badly with other drugs?
It can. Need to be aware if the patient is on ACE inhibitors, certain diuretics called potassium-sparing ones, NSAIDs, beta blockers, or digoxin.
Okay, so a full drug history is vital.
Absolutely.
Are there alternative forms? You mentioned potassium chloride and gluconate.
Potassium phosphate is sometimes used, especially if the patient also has low phosphate levels, hyperphosphatemia. You might give some of the needed potassium as phosphate in that case.
Okay, so once you start treatment, how often do you recheck the potassium levels?
Depends on how severe it was to start. Anywhere from every 6 hours to maybe every 24 hours as things stabilize. Frequent checks are key initially.
And what are the biggest dangers if things go wrong or it's not managed well?
The main worries are causing other electrolyte problems or triggering those dangerous cardiac arrhythmias.
Right.
And there's a really important practical safety point mentioned. When you add that concentrated potassium chloride to an IV fluid bag,
Yeah.
you must close the line clamp first, add the potassium, and then mix the bag thoroughly, invert it several times.
Why is that so critical?
To prevent accidentally giving a big slug of concentrated potassium straight into the vein if you forget to mix it, that could be fatal. You need it diluted evenly in the whole bag.
Wow. Okay. Crucial safety step.
Yeah.
So, wrapping this up, hypokalemia is clearly way more than just a low number on a lab report.
Absolutely. It stems from all sorts of causes, affects multiple body systems, and needs careful, thoughtful management.
It really drives home how interconnected everything is, doesn't it? That delicate electrolyte balance.
It really does. Small changes can have big ripple effects.
Which leads us to our final thought for you, the listener. We've talked about diet, kidneys, drugs, even cat litter and snake bites affecting potassium. So, what other, maybe less obvious factors in our lives or our animals' lives might influence this critical balance? And why is keeping that balance so vital for overall health?
Definitely something worth thinking about. The body's equilibrium is fascinating.
Indeed. Thanks for joining us for this deep dive.